A Fighter Bigger Than Myeloma by Adeel Khan, MD, MPH, MS. I met her during the early part of my clinical training in hematology oncology. She was in her late 70s, dressed in a rust-colored cardigan and a head wrap with patterns that reminded me of Ghanaian kente cloth. Her eyes were sharp, her tone polite but direct. You could tell from the moment she spoke that she had lived a life where she had to advocate for herself, for her family, for her place in rooms that were not always welcoming. Her chart said multiple myeloma, RISS2, but it did not say that she had first come to an emergency room at least a year earlier complaining of back pain and fatigue and had been told it was probably arthritis or old age. It did not mention that she had seen 3 different doctors before someone ordered the laboratory tests that finally began to work up her anemia and increasingly compromised kidney function. It would take another trio of doctors to eventually order a magnetic resonance imaging whose ghostly lytic lesions led down the path to a bone marrow biopsy and her cancer diagnosis. When I brought this up gently during one of our early appointments, she looked at me and said, "They don't hear pain the same when it comes from someone like me." As a Black woman from the Deep South, she had grown up learning how to navigate a healthcare system that did not always believe her. She told me stories about being dismissed, misdiagnosed, and interrupted. She was born into an era of structural violence where she would be ignored at best and mistreated at worst. She carried the weight of these moments, but she also carried strength and clarity and the kind of dignity that made people sit up straighter in their leather chairs when she entered the room. She was one of the most quietly revolutionary people I have ever known, having grown up during a time of civil rights activism. She had even taken part in bending Dr. King's long arc of the moral universe toward justice and could share story upon story from her glory days. Her myeloma treatments were not easy. Chemotherapy rarely is. She shared that there were days when her body was tired of fighting, when her bones ached, her blood counts dropped, and her neuropathic pain throbbed. In the back of my mind, I thought how tragic it was that her delayed diagnosis added unnecessary complications, and whether she too thought of that. She was fully mindful of the issues people with her skin color faced in our American healthcare system and society as a whole, and revealed how they motivated her to carry forward. "If I don't take up space here," she told me once, "then someone else like me won't either." Over the course of our visits, I came to understand that she did not see her myeloma as the hardest fight of her life. Not by a long shot. Her primary struggle was centered on life in Birmingham in the 1950s, where separate but equal was still the law of the land. Her mother cleaned houses, her father worked odd jobs, and her own prospects were uncertain. She admired the writings of Richard Wright and Jean Toomer and was not shy in sharing her passions. One day during a particularly tough visit, her disease had progressed and we were down to limited options. I found myself meandering. We went through the usual workup and discussions, laboratory test results, symptoms, and treatment options. I offered the prospect of clinical trials, but she shook her head gently and said, "I've done my time in experiments. I can't give myself to a system that gave my people so little." I paused. It was the first hint of what would become a larger conversation, not just about medicine, but about history. She was well aware of the atrocities of the Tuskegee syphilis trials in her home state, the Kligman experiments on incarcerated Black men, and the forced sterilization of women of color. As dependent upon medicine as she was in her old age, it carried a bloody stain of dehumanization racism that soured her against it. Outwardly, I had little in common with her. As a young South Asian man growing up in times more conscious of racial injustice, I was far removed from these historical crimes. Although I learned of them during my education, I did not internalize their impact on the patients in front of me in clinic. But through her, I came to comprehend just how scarring and enduring these events can be, and how they can rob someone of trust. And the truth is, the healthcare system had not treated her well. She had personal stories of doctors who did not believe her pain, nurses who assumed she was uneducated and being passed over for better options, better care, and better answers. "But I kept showing up," she said, "because that's what we do. We show up even when we're not wanted." Her stories to me were revelations. In her younger years, she had helped organize teachers at her school when they tried to fire a fellow Black teacher who seemingly spoke too loud in a meeting. She had lived through redlining, through the crack epidemic, through watching young Black men vanish into prisons, and still she rose every day and worked as a public school teacher for decades. She worked for a system that largely did not work for her. I came to admire that about her, that in simply living day-to-day life with plain dignity and acute awareness of society's issues, she promoted change by living it. "You want to talk about cancer?" she once said, half laughing. "Try walking into a bank in 1972 with a good credit score and a black face. That's a disease this country still hasn't cured." Curiously, she did not say these things with bitterness, not even anger really, just clarity, like someone who had long ago made peace with the truth, even if it was sharp. In clinic, she challenged my every assumption about treatment tolerance, about compliance, about who is difficult and who is advocating. And she taught me to look differently at the ways bias lingers in medicine, not just in data or policies, but in subtle moments. The tone we use when explaining options, the hesitations in our tests and referrals, and the assumptions we may not even realize we are making. And she did not just expect good care, she demanded it. She told me early on, "Don't you treat me like I'm anything other than your mother." That landed. And in seeing patients before me now, I remind myself to wonder who they were in their past lives, what baggage burdens them, and how it all shapes their perspectives. So from my view, she fought multiple myeloma with everything she had, but from hers, she fought something bigger, an entire system shaped by inequality. And ultimately, she made me better to realize that, not just as a doctor, but as a human being. In my years since knowing her, completing my training and beginning my practice, I reflect on her grace. I think not just about her life, but what it means to practice medicine in a world that often forgets what patients carry with them into the clinic. Generations of weight, of injustice, of strength.
Welcome back to JCO's Cancer Stories, The Art of Oncology. This ASCO podcast features intimate narratives and perspectives from authors exploring their experiences in oncology. I'm your host, Mikkael Sekeres. I'm professor of medicine and chief of the Division of Hematology at the Sylvester Comprehensive Cancer Center, University of Miami. I am so happy that today we are joined by Adeel Khan, who's assistant professor of medicine and public health at UT Southwestern in Dallas, to talk about his Journal of Clinical Oncology article, A Fight Bigger Than Myeloma. Our guest's disclosures will be linked in the transcript. Adeel, thank you so much for contributing to JCO and for joining us to discuss your article.
Thank you so much for having me. Pleasure to be here.
Adeel, I don't want to be disingenuous to our readers by acting as if we've just met. You and I have known each other for a decade since you were still in your training. I wonder if, for our listeners, you can tell us a little bit about yourself. Where are you from? And walk us through your career so far.
More than happy to. So I grew up mostly in Oklahoma, but I sort of lived around in the Northeast and here in the Southwest where I am currently. I did college at the University of Oklahoma. I did medical school at the University of Michigan. I did residency with good fortune at the Cleveland Clinic, where I happened to get to know you and have continued to know you since. I did my fellowship then in hematology oncology at Beth Israel Deaconess in the Harvard system. And along the way of all that, I did a master's in public health at Harvard and a master's of science in epidemiology at Columbia. And that pinball finally settled here to UT Southwestern here in Dallas, which very happy to make my second home.
That's great. I will say, just for our listeners, you've been a superstar since the moment you were a resident. It's been a real treat for me to get to know you over the years.
Thank you so much.
Can you tell us a little bit about your own story as a writer? You're a good writer. We get submissions from some really good writers every single week. It's a real privilege to be an editor for the Art of Oncology section. And it's always reinvigorating to me to see how many good writers there are in medicine. How did you start your journey as a writer? And how long have you been writing reflective narrative pieces?
I would say if I went back to, let's say, high school, people tend to be divided into kind of like the sciencey types versus the literary arts types. And you were kind of an either or, you didn't really have as much crossover then. But, I actually didn't mind when we had an essay due, and I liked writing back then. And when I entered college, I did a minor in English because I actually did enjoy that. And I just liked the idea of being able to put your thoughts on paper and in a way immortalizing them. And then as I sort of pursuing medicine more and more, publishing is really, it has all kinds of flavors to it. And scientific publishing is obviously what has been emphasized. But, there's so many things to talk about within medicine. There's the science and the art of the field. And as I've moved along, I've written different pieces focusing really on patient stories and interactions. And I think my motivation has always been that as I've gotten, particularly nowadays, increasingly busy, I've had the fortune and misfortune of becoming more and more busy. It's easy to lose the opportunity to really connect with people that makes what we do meaningful. And so in those times when, and they can be rare, but when you really get to connect with someone in front of you who you're helping to care for, it's really refreshing and it's rejuvenating. And I've tried to keep that with me as long as I can as I've gone through my journey.
There's a lot of jumping off points from what you just said, Adeel. I wonder if I can start with, do you consider yourself an English major who's good at science, or do you consider yourself a scientist who's a good writer?
I think I'm too humble to say either. I think I was really a science major who just happened to like writing and reading and kept that as a part of myself.
Because I think there are a cadre of doctors who are actually English majors and have learned to turn science into storytelling, and that's their entree into science and medicine. I remember I talked for a while with David Scadden about this. He's a brilliant translational scientist who's based at Mass General, who also teaches a writing course to the Harvard undergrads and who was an English major when he was an undergrad at Case Western. And we've talked about this, about how there are people, I would include myself in this, who just think different, who probably have these liberal arts brains, and they figured out a way to convert science into a way a liberal arts person can understand it.
Yeah, I mean, narrative medicine has been, I think, around all along and has only kind of been recently named as a field. But I mean, it very much speaks to that there's so much more than just G proteins in medicine.
I'm thrilled to hear that, by the way. You mentioned you were an English minor. Are there particular writers who are an influence on you? Or can you talk about what's the most recent book or article you've read?
Oh, that is a great question. Paul Coelho is someone I've liked for a long time, The Alchemist. I really liked it because I read it after I had lived in Egypt. I lived in Egypt between college and med school as a study abroad program. And I had actually been to the Fayoum Oasis, where the protagonist in that story ends up. And so it was just a fascinating story to me that I could trace some of the steps that are discussed in the book. And it's so much, and it's a story about self-discovery, which at that phase of life that I was in was, very much a theme of my own life. And so that's one that definitely stands out in my head.
Do you think reading pieces outside of medicine makes you a better scientist?
I think absolutely. I think it makes you a better human being. In some ways, I lament that so much of what I do reading now is so much just about what's in the field, what's new in myeloma, what's new in hematology, oncology. And I sort of miss the escape to reading other things and being able to pursue it. And even broader than just what a novel really offers. I mean, I grew up reading comic books too, and I've always loved superheroes and fiction, whether it's Star Wars and other things. And really, they're just stories. And the medium, there might be connotations to whether it's a comic book or a novel, but they're just different mediums. But the fact that they're just different stories is fundamental. I actually think to myself that it's so fascinating that the earliest piece of writing that we've really retained as human beings is, we believe, the Epic of Gilgamesh, which is really a story of a superhero when you think about it, and it's fiction, it's phantasmic in so many ways. It speaks to how stories are just vital as people.
And what is it about graphic novels, or my kids now, of course, call them graphic novels. We're not allowed to call them comic books.
As they've been renamed, yeah.
What is it about graphic novels or comic books or the story of a hero that appeals to us in medicine?
I think it's in some ways a parable of what we're doing. There's something so powerful and fundamental about this idea of good, evil, and we can rename it in different ways, but that you're trying to overcome something that's an issue, an obstacle. And when you think about what we do, and particularly in oncology, that's very much what we're trying to do. We're trying to overcome an illness, a disease, to try to then help a person in front of us. And it has different aspects to it. It could be someone pursuing something in a lab. It can be treating someone in front of you in clinic. But that simple dichotomy of there's something good about what you're doing because there's something bad in front of you is just the fundamental that runs through it all.
It's fascinating. I wonder if 30, 40, 50 years ago, people would have said, oh, it's because the doctor is the hero, but we don't view ourselves that way anymore. The patient is the hero. I love how you posit this as a good versus evil, the evil, of course, being cancer, and the good, everything that our patients do, and that we try to help to do to overcome that.
For sure.
You wrote a really great essay about a woman who was a patient of yours. Can you tell me a little bit about what inspired you this time to make this connection and to write about this woman?
Within the past year or so, as I had been just really the fortune and misfortune of getting busier, I lamented that I just wasn't able to spend as much time with patients in the way that I used to. One of the beauties of medical school and to some degree residency and certainly fellowship is that you just have a little bit more time as a trainee, student and trainee, where you can really bond with your patients, I think, a little bit more. And so in trying to kind of refresh my motivation, I was thinking about just kind of randomly some stories that I've kept in the back of my mind. And this patient story is one that stood out to me as I was recalling things. It was so fascinating to me because she had the disease, which I now focus on. And the way that she viewed it and the way that she viewed it as a part of her life was just so different than what I think most people think of. And in that way, it was very revitalizing that her focus in her life was part of a broader theme of the way that I think she viewed society. And this was just one piece of her own part of that much, much larger puzzle.
You really write lovingly about her and about how meaningful her context was in how you cared for her and what her experience was in the medical system. I wonder if I can read a little bit of what you wrote, because it really did grab me as well. I'm going to start out by quoting you, where you say, "Outwardly, I had little in common with her. As a young South Asian man growing up in times more conscious of racial injustice, I was far removed from these historical crimes. Though I learned of them during my education, I did not internalize their impact on the patients in front of me in clinic. But through her, I came to comprehend just how scarring and enduring these events can be, and how they can rob someone of trust." Wow, there's a lot there. Could you start with, what was your perspective as a young South Asian man growing up in Oklahoma, and what your view was of racial injustice compared to what her experience was of racial injustice?
Yeah. I have to admit, I don't know that I thought that much of it back then. And I think that's part of what it is. Being someone who was South Asian, I'm Pakistani, I have Indian roots, and coming into American history. And as we learned about it, there's so much about slavery and the theme of slavery, unfortunately, and the struggles that enslaved peoples have. And, as a relatively recent immigrant, I didn't see myself in that narrative. I didn't see myself in that historical reality. But I knew about it intellectually. I knew about the Tuskegee syphilis experiments. I learned about all these things, and you learn about how atrocious so much of it is. But again, not being so directly connected, I did not put myself in that same role as someone to view it so close to myself. I will say it hit a little bit more after 9/11, when I was randomly stopped at airport security a little bit more often in those days. And again, I think that speaks to racial injustices. I was certainly profiled looking back then. I've been held by TSA in the past, but even that is very minor compared to what African Americans have dealt with here. And this patient, in just kind of sharing her tidbits during our time together, I was not directly asking her so much of this. She was really offering a lot of it to me as we would talk, and she would be very generous in sharing parts of her story. And over time, I kind of understood the broader narrative of her life. It was clear how much of all that was actually in the forefront of her head. And I think she might have been a little bit more unique in the way that she kept it there, but she was hyper vigilant of issues of society and with the roots that brought and given society to where it is here. I had kind of gotten to know her. This is during the COVID pandemic, and this was after the injustice of what happened to George Floyd. And so it was a theme that I think people were talking about more. And so I think she felt comfortable in saying really what was quite a bit that was stewing in the back of her head, seemingly at all times.
It's so interesting. You talk about what you endured after 9/11 as being, I'm going to quote you now, minor compared to what she's been through. But even a minor affront like that can really compromise your trust. You write about her, as a Black woman from the Deep South, she had grown up learning how to navigate a healthcare system that did not always believe her. Can you expand on that a little bit? How is it that the healthcare system didn't believe her, and what can we do going into interactions with patients from different backgrounds where we're incorporating that there's a compromise of trust, and we have to make up for that?
Yeah. And I think, it's so unfortunate that so many people have stories like this, where in her case, really was back pain that was her presenting symptom. This was long before she knew me. And she had had the back pain for quite some time, but being an older woman, she was in her 70s at that time. She was not in phenomenal health for other reasons. It sounds like she was just kind of ignored, told that it was old age, degenerative changes. She did not have meaningful imaging for some time. When she finally did, after seeing a slew of different providers, that's when then revealed like there's something more significant here. And then when you kind of piece that a little bit retrospectively, and I think she certainly sensed this, and I did when I hindsight's always 2020. When I looked through things, it's like, well, this probably could have been caught much earlier. It's just that no one really, I think, listened to what she was speaking to with her pain and the gravity that was actually behind it. And it just speaks to the fact that I think we have to be more thoughtful in what we take away from patients and not to ignore even small comments because they might be revealing of something much bigger behind them.
You quote her. You have some really great quotes in your essay where you just listen to what she says and transcribe it, because what she says is very meaningful. And one of the quotes you provide from her is, "They don't hear pain the same when it comes from someone like me." Wow. When it comes from someone like me, someone like her, how was it that people weren't hearing her description of pain, something that was different, that was going on in her body? And how can we be more attentive to people when they complain about things like pain?
It's unfortunate that there's even like now data to show how, depending upon a patient's melanin content in their skin, how likely they are to get pain medications and what happens to them is different. And this is an unfortunate example of that, where I think she just wasn't heard properly. And so it wasn't addressed properly. And she was not shy about saying that. I mean, I think she sensed that. She was very clear in feeling that herself. And in wanting to have better care, she was still prevented. And hence where she had to go from provider to provider.
You've lived in a bunch of different places in the country. I mean, following your path, you've been in Oklahoma, you've been in Michigan, Ohio, Massachusetts, and now Texas. Do you think that we as providers have to have different levels of sensitivity depending on where in the country we're practicing, and how some of our patients' trust in healthcare may have been compromised in those different parts of the country?
I think absolutely. I mean, this particular patient was from Alabama, which has a heavy history that she was, again, very aware of. And for those of us reading history books, we're also very aware of too. And it's interesting how, while the US is in some ways has some aspects that are monolithic, but it's very much not so. It's very patchy and people are different. If I take one theme that we're talking about here is obviously racial injustice. But if you take something like obesity, prevalence rates are very different throughout the country, and attitudes surrounding it are also very different. And I think we do have to be mindful that in treating the patient in front of us, it's not done without context. And so how they view their illness and their situation is going to be different depending upon the state, depending upon the city, depending upon actually even the area that they grew up in. So I would say now, if you took actually a similar patient, but you put her in a very modern context post year 2000, she's likely to have different feelings of the situation around her than someone who was born, in this case, in the 1940s. And that just speaks to the fact that circumstances change, and we should be recognizing that as providers, even though it's not always easy to.
Well, it just emphasizes how very important it is to know the history of the place where we practice and how it's affected our patients' perceptions of healthcare and trust and being cared for, particularly now as there's such a movement to whitewash that history and eliminate it from major institutions like the Smithsonian. It has been such a pleasure to have Adeel Khan here. He is Assistant Professor of Medicine Public Health at UT Southwestern in Dallas and wrote just a great JCO article called Fight Bigger Than Myeloma. Adeel, thank you so much for submitting your article and for joining us today.
Thank you so much for having me. It's been a pleasure.
If you've enjoyed this episode, consider sharing it with a friend or colleague, or leave us a review. Your feedback and support helps us continue to have these important conversations. If you're looking for more episodes in context, follow our show on Apple, Spotify, or wherever you listen, and explore more from ASCO at asco.org/podcasts. Until next time, This has been Mikkael Sekeres for JCO Cancer Stories, The Art of Oncology.
The purpose of this podcast is to educate and to inform. This is not a substitute for professional medical care and is not intended for use in the diagnosis or treatment of individual conditions. Guests on this podcast express their own opinions, experience, and conclusions. Guest statements on the podcast do not express the opinions of ASCO. The mention of any product, service, organization, activity, or therapy should not be construed as an ASCO endorsement.